Good afternoon, ladies and gentlemen. I think I'm the only chair who will be starting the session early. I'm going to do that because I have a feeling there will be a lot of questions that will come up afterwards. So my name is Leonor Ponferrada. I'm the chair of the Council of Nephrology Nurses and Technicians Program Committee. And I'd like to welcome all of you to this session. Apparently a very, very popular topic, but I also heard, Dr. Golper, that you have fans here who came just to see you and hear you. So now I'd like to introduce our speaker, Dr. Tom Golper. You can see on his slide, Dr. Tom Golper is an emeritus professor of medicine at Vanderbilt University Medical Center, and he also held the position of medical director of Medical Specialties Patient Care Center at the same institution. Presently, he serves as professor of medicine and part-time faculty at Larner College of Medicine at the University of Vermont, where he continues to manage patients on home dialysis. Dr. Golper will be presenting on the topic of hemodialfiltration. And before I give the mic to him, I have to share and quote a joke that he claims he often makes when discussing dialysis physiology, and that convection plus diffusion leads to confusion. So let's hope Dr. Golper will educate us further and clarify this confusion for us in his presentation, and hopefully also provide a hopeful message of the possibility of implementing HDF in this country. Dr. Golper?
Thank you, Leonora. So we're starting early, so that gives me a chance to do a couple things. I would like to get a feel for the audience. So let me, before you raise your hand, because I want you to identify your, so the categories will be practicing physician, a training physician, nurse practitioner, PA, a staff nurse, and Danielle is here at the technicians, okay? So that helps me direct my remarks. So how many in here are practicing physicians? So it looks to be about half to 2/3. How many are training physicians? Okay, and how many are nurse practitioners or PAs? A few. How many are staff dialysis nurses? Okay, well, you see, that's the mix, and that alters things. It would have been easier if it had been 90% one and 10% the other. All right, so I'll have to direct my remarks that way. Did you see it, Lenore? There was a spread of everybody. Okay, well, that's fine. So the original chore was to, I forget even what the title was, so I changed it. That's been my norm. So are we ready? And in this country, we're not ready, not quite. How is HDF different? And then if you go to the original title up there, the primer, is because I really think American nephrologists and a lot of you are going to need some basics. So that's what the intent was, okay? So with that, disclosures, and so you can read the disclosures, but I do want to acknowledge some people who sent me some slides or over the course of time, and that's at the bottom. And I'm not going to necessarily identify where those slides came from, but I've been taught a lot by a lot of people on this subject. They usually want us to give you our objectives. I hope I can get us through some of those objectives. I'm not altogether sure what the next steps are. I'm not altogether sure what the feedback will be, but I think my goal is to help you get started with these objectives. Whether we achieve them, at least start to think about them. So the outline is here, and I want to start with terms and definitions. And I don't know if some of you saw Dr. Polevsky and me talking a few minutes ago, but he was harassing me about definitions. And you heard Leonora talk about definitions just a minute ago. So these are the topics in this section that we'll talk about. But let me start with hemofiltration so that everybody is working from the same starting point. And so Andre Kaplan actually put this in a AJKD paper many, many years ago. And so hemofiltration is best described by this coffee maker analogy, where you open the spigot at the bottom, and so this very dark coffee, the color of the dark coffee is shown here, is allowed to drain out. And so that's classic hemofiltration. And you're starting with a full tank, so the level is very high. That's hemofiltration. And I can control the volume. I can let that volume come down by just keeping this spigot open. And I can improve the water overload condition. And so Emil Paganini originally described this as continuous ultrafiltration. So this was simply a phenomena of bringing the volume down. But if I put substitution fluid in, then I actually am diluting the concentration of the coffee, and so the coffee is less dark. And so the spigot is open here, and the substitution in fluid is here. And you can see from this arrow, I'm in control of where this level is. And so this is pure hemofiltration. The way we think of it is in blood cleansing phenomena. This rightmost coffee maker is pure hemofiltration. And so the coffee would be the uremic condition, and if it's not as dark as it is over here, then we are controlling the uremic milieu with hemofiltration. So let's continue with definitions. So solutes here, the term is used to mean molecules or ions dissolved in the water component of plasma. The water component of plasma is about 93% of plasma, roughly. And then so it's the non-cellular components of plasma minus the protein. It includes the protein because it's dissolved in it. Now, solute nomenclature, when I was growing up, we had small, middle, and large. But what's happened, partly because of the innovations in dialysis therapies, the terminology's changed. So the small solutes are still considered those ones less than 500 Daltons. But in the middle molecules, there's been sort of a small change in the terminology. So small middle would be roughly 500 to 5,000, roughly. And large middle would be 5,000 then up to almost the size of albumin. And then basically albumin defines the larger molecules. Now you're going to see these molecular weights come up again later, because it's important for you to understand the difference of solute movement by diffusion versus convection. So you maybe want to keep in mind the newer areas where the distinction between middle molecules is small middle and larger middle. So the solvent is the liquid that the solutes are dissolved in. So for the most part, that's going to be plasma water. The solutes have to get from inside the cell, where we think they might be doing harm, to outside the cell. Because if they're not outside the cell, they're not going to get into plasma water, and they're not going to be removed by any of the therapies that we might apply. So they have to be in the plasma water to be removed by either hemodialfiltration or hemodialysis. Now you can see why we have to go over the basics for you to get to the difference between hemodialfiltration and hemodialysis. Many uremic toxins are the solutes that I'm referring to. So we may think of a solute like the sodium ion. Some people may not think that's a toxin. Some people may think it is. But imagine whatever that toxin is that you're thinking about, and these same criteria are applicable to that toxin. So the ones that come to mind right away for you are hydrogen ion and potassium. But now let your imagination talk about the unknowns, because what I'm going to say with regards to solute removal refers to those unknown molecules that we aren't necessarily going to go into today. So diffusion is the passive movement down a concentration gradient. And we're going to spend some time on that in just a few minutes. So an example of that would be a high urea level in the blood, and the urea level in the dialysate is 0. It's the opposite of that for bicarbonate. And again, I'll show you that in the cartoon. So there are materials in the dialysate that we want to put in the blood. And bicarbonate is one, could be calcium, might be another. So the diffusion is going to work both ways. And the driving force for diffusion is the concentration gradient. And the concentration gradient is things we're going to spend a few minutes on. Convection, and this is what Dr. Pilevsky and I were talking about a few minutes ago. Classically, it's the movement of heat through something. And the best thing to think about that is iron, the metal, is the movement of heat through metal. But we, in our field, in fluid mechanics and in dialysis, we have taken that term to mean the movement of a solute that simply accompanies the movement of a fluid. And that's how we'll use convection in this setting. And so if you ultrafiltrate plasma water and it contains solute, when that plasma water moves across that membrane, it is going to take the solute with it. So in essence, the solvent, the solution, is dragging that solute across the membrane. And that's why you may have heard the term solvent drag. So the solvent is dragging the solute with it as the fluid comes across the membrane. So going back to this coffee maker analogy, this black material down here is convectively derived solute that is being removed. Convectively derived. And I'll explain to you pore size in just a few minutes, but you can think of this as a component of plasma water. So this box in here contains a component of this plasma water, and on the filtrate side, the contents look very much like the contents here, up to the status of the size of the pores of that membrane. And I'll show you that in the cartoon in a few minutes. But you can think of convection is going to be the contents of that plasma water getting through that membrane in the same concentration that they were when they were on the plasma side of the membrane. And that's the concentration on the filtrate side. So hemodialfiltration is the simultaneous solute removal by that process of diffusion and the process of convection. So they're additive. So that is what hemodialfiltration is. Let's go in more detail on the mechanisms of action. So for hemodialysis, we have to start with that because this is a combination of hemodialysis and hemofiltration. So, can the solute, that imaginary solute that you're thinking of, that's a uremic toxin that you know about and no one else does, that's the one we're thinking about, can it get into plasma water? If it's in plasma water, can it get through the membrane pore? And I'll show you that in a few minutes. It's concentration gradient dependent, so there has to be a higher concentration on the blood or plasma side relative to the dialysate side. You may hear me use the term dialysate saturation, and by that I mean that the concentration in the dialysate is equal to the concentration in plasma water, hence equilibrium has been reached and there is no concentration gradient. So equilibrium, dialysate is fully saturated of the solute in question. Now, let's think about some therapies that we apply. In in-center hemodialysis, that's a high dialysate flow. In a few minutes, I'll use an example of 500, but some people use 600, 800. It's high. And so the dialysate is only partially saturated because it's blowing through there so fast. Those molecules only can move so fast, and that dialysate is not at all saturated. Now, the good news is the blood extraction is high because that concentration gradient is very high. All right, so all of us have some experience with PD and this type of hemodialysis that some of us apply using the next stage system where dialysate is scarce, that's a low dialysate flow situation. And so saturating the dialysate is efficient because I don't have very much of it. Whether it's next stage PD, in either case, I don't have a lot of dialysate. So if I want to clean the blood, I want that dialysate saturated. Now the problem with that is that the blood extraction is quite modest. And that is why these therapies tend to be longer or more frequent in order to remove the same amount of solute in absolute amounts. So let's look at our schema for hemodialysis, one you're very familiar with. So potable water comes in from your commercial or your city water system. It's got various pretreatments, eventually goes through an RO system, and then it's eventually is pumped to your a filter, a single filter on our machines. We happen to use Fresenius machines where I work, and this filter is called a DiaSafe. How many of you have some familiarity with the DiaSafe device? Okay, that term's going to come up again. So, and it's not the only one. I don't mean to necessarily advocate it, but that's what that is. That's a DiaSafe filter that's cleaning that dialysate, which is now going to the dialyzer. And blood is passing through. That dialysate's cleaning the blood here, and then it's going down the drain. So that's the hemodialysis circuit. Within the hemodialysis filter, diffusion is occurring. In black, and with the black arrow, are solutes that are on the dialysate side that we want to diffuse into the blood. And in yellow are solutes that are on the blood side that I want to diffuse into the dialysate. So that's the direction they're going. We'll come back to these pumps in just a few minutes when we talk about the flow of fluid. So here's a schema of a membrane. It's a cartoon, as you can tell. And I want you to concentrate on this small dot, which is a smaller molecule, and this red dot, which is a little bit larger molecule. And these are the pores of the membrane. Now, I'm not going to go into pore density, which is how many they are, but I do want to talk about pore size. So pore size has two dimensions, length and width. So, for example, here's a wide pore right here, and here's a narrow pore, and here is a short pore, and here is a long pore. So two dimensions of pores. Now, let's look at this small molecule. And this molecule is going to diffuse. We're not going to do any convection here for a minute. We'll come back to convection. Same cartoon, but we'll come back to convection. So the Brownian motion of these molecules, the kinetic energy of these molecules colliding, for Dr. Pileski, that would be the second law of thermodynamics. Okay, for anybody else who doesn't understand it, he does. So these molecules have kinetic energy, and they're going to diffuse to get over here. Now, this small molecule can go straight shot this way, right through that small pore. That small molecule can go this tedious way. It can go this way. It can go a million different ways. But let's look at this little bit larger molecule. It can't fit through this area, and it's not likely to fit through this area. And so it's got to take time to find its way down this pathway. And remember, it's just bumping into things. That's the energy of the kinetic energy of that molecule by diffusion. So it's got a low concentration on the dialysate side. I'm going to change out pointers here. So there's a low concentration over here, and so these molecules, by, again, the second law of thermodynamics, they're going to try to move through their kinetic energy down here. But this one can only find a pathway that will allow it to go there. So that's going to take a lot longer. So these molecules are going to move a lot more slowly. The larger it is, by diffusion, it's going to move a lot more slowly by diffusion to get from the plasma water side over to the dialysate side. So how would I maximize this? Because remember, what we want to do is get rid of these molecules. So I would want to increase the concentration gradient for diffusion. And To do that, I am going to want to increase the delivery of solute to the membrane by increasing the blood flow rate, right? Picture this room, is the blood is going through here, and if there are only 3 of us in here that come through in a minute, there's not very many solutes for us to remove. But we just got this whole room in 3 minutes. There's a lot of us, a lot greater opportunity for its removal. Well, let's look at what that looks like. So let's look at increasing blood flow rate. So shown across here is the blood flow rate, and shown here is the clearance, and then here are the molecular weights of different molecules. And let's look at where we tend to operate. So we're going to use 350 as an example. And this is where we tend to operate. And you can see that there's a pretty big difference between even the clearance of urea and creatinine, even though the molecular weight difference is not much in absolute molecular weight units, but creatinine is twice the size of urea. But you can see there's a significant difference. Well, I ask you to think about the molecules that are in your imagination that are the toxic molecules. Not that these aren't necessarily toxic, but think about your imaginary ones that are of these sizes or larger. And you can see that if they're this size, then we're not doing such a great job. You can see these lines are starting to flatten out as you move to the right. And so this is where the attention needs to go for molecules like this. And that is why we're going to end up talking about hemodialfiltration and its benefit for these molecules of this size. So another way to increase solute is to increase the dialysate flow rate. So let's look at dialysate flow rate. So now on the horizontal axis is dialysate flow rates. We're still going to use clearance on the vertical axis. The same molecular species are shown here. And let's throw in a line where we operate. So we're operating, now some people are moving off to the right, but most of us the dialysate flow rates are in the 500 or 600 range. So this is where we're operating. And again, you can see that the curves for these solutes have flattened out. And again, the same argument. If molecules of these size are the pathogens that you're dreaming about, we need a better job at removing them. And that's not happening with dialysis the way we're doing it now. And that's the point of this discussion. Now, we also run dialysate countercurrent. And I think that at least a lot of the trainees that I work with don't necessarily really understand why that is important. And I want to take the time to do that, if you'll bear with me. So this is not an oh my God slide. Bear with me a second. It's going to get worse. So this stands for concentration blood in. And so the purple arrow pointing up is the higher concentration. And this is the membrane of the device. This is the concentration of the blood exiting out. All right, and this is the concentration of the dialysate going in, and this is the concentration of the dialysate going out. So the dialysate flow and blood flow are going the same direction, and that's called co-current flow. And the concentration gradient, this red arrow is showing the concentration gradient at this point along the membrane, but you can see that the concentration gradient is really large here, but it's minuscule here. All right, so that is co-current flow. Let's look at the opposite of that, which is countercurrent flow. So the same abbreviations, the blood flow is still going from left to right, but now the dialysate is going from right to left. And so at the time when the concentration of blood out is at its lowest is when the concentration of dialysate coming into the system is also at its lowest, leaving you this large concentration gradient here as opposed to this small concentration gradient here. And so the overall concentration gradient is reflected by the area between the curves. And I think you can see that the area of the green area is much larger than the area of the red. And so that was the rationale when we developed dialysis to run the dialysate countercurrent to the blood flow direction. Another way to increase solute removal besides the blood flow rate, the dialysate flow rate, and the countercurrent blood flow, or dialysate flow and blood flow, is the surface area. So that is increasing the contact opportunity between blood and dialysate. And so for devices that we tend to use now, here's clearance here, and there's blood flow rates there, and as we said, we're kind of functioning out here. And you can see that a 1.5 square meter dialyzer has almost a 40 milliliter per minute difference than, say, a 1.9. Most of us are using probably 2 or 2.2 square meter dialyzers. So these are the things we're doing now in hemodialysis to increase solute clearance. And I'm arguing that may not be good enough. So we've gone through the mechanisms that we're using, at least in 2025 in the US, to increase solute clearance. Another way to increase solute removal is increased time of therapy. And the argument for that is it allows you to get molecules that are trapped perhaps inside cells, or maybe even bound to protein that are in equilibrium with being unbound to protein, but giving them time to get out of cells or to unbind from protein and be available for removal by dialysis. Now I'm going to come back to time at least 2 or 3 more times during this discussion. And then finally, the last alternative, and the reason we're here together today, is adding convective removal to diffusive removal. Well, I showed you this earlier, and I said this is the convective removal component to a pure hemofiltration system. But we do convective removal of solute all the time. So is anybody willing to admit they're not familiar with that term URR? Okay, so I'm going to start with the assumption everybody is familiar with the term URR, the urea reduction rate. So Tom Deppner put this out several years ago, where he looked at URR relative to that per session KT over V, and looking at different degrees of ultrafiltration. Now I'm going to magnify this in just a minute, but I wanted to start with that URR of 70, which most people doing hemodialysis in the US would say that's a very reasonable URR to strive to achieve. So we're going to stick with that 70 number. And that's, so this can be this red line. And we're going to zone in on this area of the curve here in just a second. So if you will allow, we're going to magnify this box. So it's the same thing, just simply magnified. So that's what this looks like, but it allows you to read over here what's going on. So that for each of those URRs across here, the KT over V is on the vertical axis, and this refers to the fraction of weight removed. And so this first line, this one to the furthest to the right, is no ultrafiltration. The weight did not change during the course of the dialysis. The 2 is 2%, and 0.04 is 4%. All right, so now I want you to stick with me, because we're going to take an 80 kilogram person and we're going to remove 4%, which is going to be 3.2 liters. Are you with me? That's where that number comes from. So 4% of weight, so that's that 0.04. So we're on that second, or I guess it's, well, the third line in from the right. That's what I want you to. And so if you look at the KT over V, which some people use KT over V, not URR, so if you look at the KT over V, it's a greater than 1 contribution just from the convective removal of the solute. So you're using, even in the standard hemo and your hemo units, you're doing convective removal. And it is representing, which could be 10-15% of your solute removal. All right? So now we're going to talk about just expanding on that. But I wanted to make it, give you a reference point for what you're currently doing. So so let's talk about the convective removal of solute. So some of the same criteria still apply. Can it get into plasma water? If it's in plasma water, can it get through the membrane? For example, if it's unbound to proteins. Now, if it's bound to small proteins, it may get through. If it's bound to large proteins, it has to dissociate from those large proteins to free up so it can get through. Now, that can happen. It just takes time. And so one of the ways that we sort of refer to this as the sieving coefficient, and we're not going to discuss that here, but if you hear the term, the sieving coefficient is the concentration in entering the device in the plasma water and divided by the concentration in the filtrate. So that is a reflection of how much of that free substance can get into the filtrate. It's okay for purposes of this discussion. We're not going to need that term, but in case you hear it, that's how it's defined. Now, the solvent, which is plasma water, is dragging the solute. So the solute is moving with the ultrafiltrate. It's induced by the hydrostatic pressure, and we call that transmembrane pressure. And that pressure is generated in multiple ways. We're going to have another cartoon that deals with that. But for the majority of hemodialysis, the way we do it now, the majority of that transmembrane pressure comes from sucking on the dialysate outside. That's the difference between the machines and the dialysis. When Pilevsky and I started dialysis 40 years ago, that's not how it was done. We put a clamp on the venous return line and we raised the pressure on the blood side, as opposed to sucking on the dialysate side. So that's how we do it now. So when people say dialysate sucks, they're right. All right? And increasing ultrafiltration will proportionally increase the clearance of larger molecular weight species. We're going to spend a fair amount of time on that concept, but I'll explain it in cartoons as to how that happens. But again, let's go back to this is the convectively derived solute in pure hemofiltration. So there's no dialysis going on. Now let's just take this scenario and let's add dialysis to it. So in hemodialysis, we're going to, in hemodiafiltration, we're now going to expose this black material, this dark coffee, to solute-free dialysate, and we're going to bathe it with solute-free dialysate, adding now diffusion to this description of convection and hemofiltration. So this is a cartoon of the molecular sizes that are removed. If you do a pure hemofiltration, let's go back, that is pure hemofiltration. And if that's pure hemofiltration, you can see that a much larger molecular weight species are removed by that. And again, I'll explain that to you in a minute as to how that happens, as opposed to the diffusive process in dialysis. And across here are arrows pointing out the various molecular weights of the substances that will be our reference substances. All right, so let's go back and now follow the red dots again. We have previously followed the red dots in this cartoon as kinetic energy. The Brownian motion kinetic energy allowed the diffusion of these molecules to find their way here. Now we're going to do the same thing, but we're going to add more energy to the system. Rather than the kinetic energy of these molecules, I'm going to take a spigot right here and blast water through that downward there. Now you see the energy that's added, so this substance is going to find that pathway a whole lot faster with water blowing through there than it would by just the process of diffusion. And now you're seeing how the process of convection or driving water flux through there will enhance the movement of this molecule. This molecule had no trouble. It's going to go this way. It's going to go this way. It's going to have a minimal effect on that smaller one. The major effect is going to be on that larger one. And that is the value of the filtration, the convective component, added to dialysis in the process called hemodiafiltration. Now I want to zone in on these fibers. Okay, so almost all of us are using hollow fibers these days, and so we're going to take a look at these fibers, and we're going to look at it from a variety of different perspectives, because that's the dialyzer that we're going to be using. So I'm going to take this fiber, this one that's hanging loose here, and I'm going to cut it across where the red line is. All right, and now we're going to look at the fiber. It looks like this, and now I'm going to ask you to look at it this way. So now we're going to go from this way, looking at that fiber. And I want you just to stick over here. So the larger molecules are the larger red ones. The smaller ones are these blue ones. all right? And so, and we're going to come back to this cartoon again in just a few minutes. Let's look at what's going on during standard hemodialysis. You all know that the blood is moving countercurrent to the dialysate. And so picture this, now blood is moving from our left to right. The dialysate is moving from our right to left. And there's a little positive sign here because there's a pump here, and there's a pump here, so there's a little positive sign. All right, and if you, because of this, this is the greatest degree of pressure gradient. This positive versus this negative is here, and this is where ultrafiltration is occurring in standard hemodialysis the way we're doing it now. On the back side of this, it's very possible that there is back transport, movement, depends on the pressures, but this, in standard hemodialysis, under certain circumstances, we're going to get movement of dialysate back over here. Now let's put in some disclaimers here, just I want you to be aware of the schema. All right, so on the blood inlet side is where the bulk of the ultrafiltration is occurring. You've got a pump here, which is putting the greatest degree of pressure right here. There's friction of blood. As this blood moves from here to there, there's friction. That blood is not water. It's got material in it and it makes it thick. You've heard the expression, blood is thicker than water. All right? So that creates friction. So there's a pressure drop as that friction consumes pressure. As you go from here to here, you're losing pressure. All right? And so the greatest positive pressure is here, and that's why the movement is, of ultrafiltration is there. Furthermore, as this blood is moving from the inlet of the dialyzer over here, and this is water being ultrafiltered out, now the protein concentration is increasing. And that creates oncotic pressure, which slows down the ultrafiltration. And under the right circumstances, this may create a circumstance where there is movement of water from here on the dialyzer exit site, blood exit site. There may be movement of water from the dialysate into the blood. Over here, fresh dialysate is not very viscous. It's water. And it doesn't require much of a pressure, but nonetheless, it's still being pumped in. It's not getting in by gravity. It's being pumped in. Over here, remember we said dialysis sucks? Well, here's where the suction's going on. So this is where the dialysate's coming out. So I want you to understand that this is what you're doing in almost all your hemodialysis treatments. The degree of these black arrows going up, they may be tiny. They may be larger. It depends on all these other parameters going on. The point being is that you're in control of these parameters. And with the newer hemodiafiltration machines, they're in control of these parameters. And they can accentuate this. So that's what we're going to get into in just a few minutes. Now, let's go back to this cartoon. So remember, this was the cross-section of the fiber. And so only molecules that can fit through the pores by diffusion will get there in the dialysis process. So very few of the larger molecules, the red ones, get through by diffusion, but a lot of these smaller blue ones are getting through just fine, because they can find their way through here. They can find their way through this big pore or even this smaller pore. They're smaller and they have no trouble getting through. Now, if I drive water through there and I can create the process of convection, I can now enhance the ability of those larger molecules, the red ones, to get on the outside of that fiber. So it's now getting into the dialysate and the filtrate compartment. So I've tried to take this from several different slants for you to understand the movement of molecules by their size. This is, again, the same cartoon that we saw earlier, that when we think of, in terms of convection, you just take a hunk of the plasma water and move it across the membrane. And everything in that hunk of plasma water crossed the membrane. as opposed to diffusion, where you have no other driving force other than the concentration gradient to get those molecules across. Whereas if you have a driving force of water from this side over to this side, that brings with it, by solvent drag, those much larger molecular weight species. So again, a cartoon, if you were to look at a molecular weight and removal, let's focus to the far left. So let's take a tiny molecule like urea. And so you can see that the total clearance is almost all diffusive for a small molecule like urea. But when we take a larger molecule, make one up, take a hormone, a 10,000 Dalton hormone. And so hardly any of it, if any, is removed by diffusion. It's almost all removed by the convective contribution. And Andrew Davenport made a nice cartoon of this. And so what we have is the ultrafiltration rate here for 3 different molecules, a small one, a medium-sized one, and so this would be certainly a medium-sized. This would be a larger medium-sized molecule, all right? So urea being the smallest one. And so these are the ultrafiltration rates. And so think about what you're doing in ultrafiltration rates now before we look at the next slide. Just think about what your ultrafiltration rates are, all right? Because you're trying to keep them below 13 milliliters per kilo per minute, right? So just think about what that is. All right, so in hemodialysis, that would be roughly where this red arrow is. All right, and so if you look here that you're say it looks like 10 milliliters a minute ultrafiltration rate, 600 milliliters an hour, not unreasonable to what you do. A tiny amount of the urea, which I showed you earlier, is coming from convection. The bulk of it's coming from diffusion. If we take this molecule, a tiny amount is coming from convection, and a tiny amount is larger amounts coming from diffusion. Same thing with this molecule, except that if you look at the total fraction of what's removed, it's still it's tiny, tiny, and tiny. And that's what you do in hemodialysis. All right, let's look at hemodiafiltration. The ultrafiltration rates in hemodiafiltration, as you're going to see in just a few minutes, are 100 milliliters a minute. Oh, wow. Okay, you're not used to that. Now look at it. So the contribution, almost all of this larger molecule, almost all of it is due to convection. Whereas here, if you take urea, a substantial amount's coming from convection, but still the majority is coming from diffusion. So when you heard the argument that adding convection contributes to the removal of larger molecules proportionally much greater than during a diffusion process like hemodialysis, that slide explains it best of all. And that's why I'm using that slide from Andrew Davenport. So in addition to hemodiafiltration, some people have the strategy of using more open membranes, and those are called medium cutoff membranes. I'm going to come back to that at the very tail end when we talk about a trial that's looking at that. But I think the only one that's available in the United States is the Theranova membrane. And so the only thing that is comparable at all, and I'm not even sure that the right comparisons have been made yet, to hemodiafiltration would be dialysis using these MCO membranes, which stands for medium cutoff membranes, with the Theranova membrane being the example of that. But again, we'll come back to that at the tail end. So why would we consider hemodiafiltration? What are the outcome benefits to patients? So there were 4 randomized controlled trials, and this is a summary of some of those. We'll zone in on them in just a minute. But if one took at those 4 trials, this is before the CONVINCE trial, which we're going to talk about in a few minutes, and we looked at the if a certain volume was achieved, and that's what these numbers are, convective volume means the degree of ultrafiltration. So when it says greater than 23, that means 23 liters per normal body size of 1.73 meters was convectively removed during that session. So if the ultrafiltration was 1 liter, and 23 liters was convectively removed, then they replaced 22 of the 23 for a net removal of 1 liter. So that's how you would read that. And so you can see from this that if one looked at these 4 randomized controlled trials, there's maybe a little suggestion of benefit for if all the patients are considered. But if one takes those 4 trials that were originally done and looks at the large convective volume removal, then it's far less controversial. There's a much more impressive benefit. And the same thing holds true with cardiovascular. So it was looking back at these trials retrospectively that prompted the trial that we're going to talk about in a moment or two. So, but let's look at those 4 trials. And so those 4 trials, by their names, were referred to as CONTRAST, which was the study done in Holland, Canada, and Norway. The Turkish trial done in Turkey, ESHAL, the E stands for Español, so that was Spain, and the Frenchy study was actually more elderly patients than otherwise. But nonetheless, these are the 4 trials that I just referred to that led to looking in great detail at the convective volume as the benefit to hemodiafiltration. So that led to the CONVINCE trial. So the CONVINCE trial was published almost 2 years ago in the New England Journal, and this is the reference. It's referred to as high volume because the convective volume had to achieve a certain amount, and I'll show you that in a slide in just a minute, as opposed to any contribution by convection. This was specifically designed that there would be a high convective volume, and that was the purpose of the study, was to look at the contribution of how much convective contribution was necessary to achieve the clinical benefit. So the study sites, a lot of people would say, oh, this is Fresenius study. No, that's not true. Look at the study sites. It's all over the place, okay? And in fact, even though the Fresenius clinics may have been the most numerous, by all means, you can see all over the place, it's much more than Fresenius clinics. And when people tell us they can't do it, we can't do it in the United States, I kind of look at Eastern Europe and say, why not? So here are the data on mortality and in the follow-up period, and you can see that this is a statistically significant difference between the mortality on the high-dose hemodiafiltration versus the high-flux hemodialysis. That the comparator was high-flux. So the mortality hazard ratio was decreased by 23%. And here's that convective volume I said. And so the design of the study was to keep this convective volume up. And when you see a slide like this, this tells you that the conduct of the trial was well done. They achieved what they were supposed to achieve. And so, this is the convective volume over the 3 year of the study. So you can see they did what they were supposed to do. Now, interestingly, the KT over V for urea was actually higher on the high volume hemodiafiltration. Now this degree of difference, this 0.1 of a KT over V, we might think is clinically significant. At least from the hemo trial, it wouldn't turn out to be clinically significant, but you can't separate that. Now, whether you think urea is the issue, I don't think so. I think it's other molecules, but nonetheless, you can't hide this, that the KT over V was a little bit higher in the hemodiafiltration group. But let's look at the outcomes from the CONVINCE study. So roughly about 680 subjects in each arm. So that's high flux hemodialysis versus hemodiafiltration, and the hemodiafiltration had in excess of 23 liters of convective volumes. And so here would be a table, but I highlighted where the significance is. So the all-cause mortality, that's where that 23% reduction is referring to. The non-cardiovascular mortality and the infection mortality, including the COVID, was all significantly lower mortality in the convection group, in the hemodiafiltration group. So what did that matter to patients? Because those are just statistics. So the other part of that study was published in KI Reports, and Matthias Rose did this, and this is the patient-reported outcome. So you're going to see in just a minute PROM, and so patient-reported outcome measures, and they used a certain set of measures, which I'll show you in just a second. But this is the reference to how the patients felt they were doing, which is what we really care about, as well as mortality. So they used this the system called PROMIS, and the standard tools are shown here. And I don't want to delve into this. This is not my specialty at all, but I think I can appreciate it as well as you will in just a minute. So these are the tools that were used when Rose and colleagues described the patient-reported outcomes in CONVINCE. So don't worry, you're going to see all this in just a minute. I'm going to magnify it, but I wanted to highlight a few things. So these, to get in the trial, they had to be above the age of 18, on hemo for more than 3 months, and they had to be able to achieve a hemodiafiltration convective volume in excess of 23 liters. That was a requisite to get in the study. Then I want to highlight the next part of that. Stefano, you can see why I'm preoccupied with time, all right? Because to get in the study, they had to be willing to participate in a session of 4 hours. Now, I ask you, American dialysis people, how many of our patients are going to, a priori, agree that they're going to do 4 hours? Okay? And so there's a difference here, all right? Now, let's look at the data. So I said I would increase the size of these. So over time, the physical function deteriorated in both the high-volume hemofiltration and in the hemo, but it was slower deterioration in the hemofiltration. And that's the only one I'm going to zone in on. Anybody who wants the slides, all you have to do is request them. And plus you can have the reference for that study that Rose wrote. But in every circumstance where it's looked at, the benefit is of hemodiafiltration. So even though both patients in both groups declined, they declined at a much slower rate during the hemodiafiltration. So in summarizing those, because that was too much data, so both groups had a decline. But when there are differences, there was always a slower decline in the HDF group, and it was in those categories. So from the patient's perspective and from the mortality perspective, the high-volume HDF did well. So let me kind of wind down with this last section of the outline. Let's go over now, so this is your hemodialysis schema. So this is that diasafe we talked about. It's cleaning the dialysate before it goes in. And this is your hemodialysis schema. So how does hemodiafiltration differ? So there's a second filter in the system, and that filter is cleaning that water yet a little bit more, and that water becomes substitution fluid, and that is going into the venous bubble trap. So here, we're taking off, if I need a 1 or 2, let's say I need 1 liter off, and I want to achieve a convective volume of 23 liters, then 24 liters is going to come draining out here. And that means I'm going to put in 23 here, and this is that convective volume that you heard described just a few minutes ago. So that's the unique component of the device, of the machine, with a heck of a lot of electronics that make it also unique. And if you get a chance, I don't know how open it is, but I know that the Fresenius folks are showing their machine that's been approved. If you get a chance, you either go down to the exhibit hall, or they're having a session this evening, but it's worth seeing. So schematically, it may look like this is the only difference. It's not the only difference. There's a heck of a lot of electronic differences going on inside that machine. Now, prior to 2024, the only way we were doing hemodiafiltration in the U.S. was using nephros. So I had nephros going at Vanderbilt. Does anybody had an experience with that? Okay, that tells something right there. Okay, we did it for 6 months, and then the staff said, you got to stop. This is nuts. It was very tedious for the staff, and it was clunky. And I was friends with the people that were developing it, so it didn't work so well. And it didn't achieve any. We were able to do 8 or 10 liters of convective volume, which is not going to get the job done. So last year, the FDA approved the other device other than the nephros, which is this 5008X. It looks like a standard hemodialysis machine, but it's got a couple features. It's got that extra diasafe, as I told you, but the electronics in here are just incredible. And then pretty much these dialyzers are special dialyzers, and there's, I think, a couple different sizes that it looks like there's 3 different sizes here. So, but this will be, I guess it's available now, except we don't know how to buy it and we don't know how to roll it out. So, I mean, it's legally available. It's, all right. So that was, it was approved, and I mentioned that. The blood flow rates need to be reasonable, and I guess some people can achieve this with the central venous catheter. I think the hematocrits should probably be less than 35 for reasons you'll hear in just a minute. And I'm a stickler on time. I still think that we need to be dialyzing most adults for 4 hours or more for a variety of reasons. But so if the ultrafiltration rates are near 100, which mils per minute, which I mentioned earlier, and if you want to get 24 liters off, and you're trying to keep the filtration fraction low, you can see why I'm sort of inclined towards these longer times. But that's a controversy. Time will remove larger molecules, and that doesn't matter whether it's hemodialysis or hemodiafiltration. And this, I used this figure before. If you want to do 23 liters to take off and then substitute 1, so that's 24 liters off altogether, and in 240 minutes, so that's where that 100 milliliters a minute of ultrafiltration rate. And I only use those figures so you can relate to them, because it's easier math to relate to figures like that. If you've got a hematocrit of 35, then the plasma is 65% of that. And so now you can see where some of these numbers come from. And the beauty of the Fresenius system, that 5008, is it will do a lot of this mathematical stuff for you. But I'm a stickler on this. I think you should understand it. The thing is, you don't have to. That machine is going to forgive you not understanding it, so I'm from Tennessee, and in Tennessee they have a term, I'm again it. I'm again, you're not understanding it, and that is why I'm going through the detail in this way. But you do, there are some considerations. You do need a blood flow that is going to deliver plasma water so you can ultrafilter at that rate, because the more viscous that blood gets, the higher the pressure inside the fibers, and the more viscous is the blood and more is the tendency to clot. And so again, I come back to my admonition that time forgives a lot of things, and I think we should dialyze longer. Now, with regards to cost, so let me take you through this. So pink is sort of a category towards red, which is bad, okay? So that's more costly. Green is a category towards go, which is less costly. So I'm orienting you to the slide. All right, so on the left, we're going to say the health benefit is not so good. To the right, the health benefit is better. So let's follow that arrow. So better health benefit. So now you can see my 4 quadrants, all right? By good and bad health and more and less costly, all right? Now, in case you didn't come to this, I'm going to help you with it. If it's more costly and less good for your health, that's a no-brainer. Don't do it. If, on the other hand, it's less costly and a health benefit, that's a no-brainer. Do it. Right? You with me so far? All right. So it's these other 2 categories that require thought. So let's put all that together. These 2 are no-brainers. Don't do it, do it. And these 2 we have to think about. All right? So the question is, where does hemodiafiltration fit into that? And this is where several of us think it will fit in. Now, I want you to look at the arrow. So this arrow is quite a bit stronger towards the health benefit, and it is to the more expensive benefit, but it's not a steep arrow. This is realistically probably where it sits. And when you consider those countries in Europe that are doing hemodiafiltration, now I didn't know that Romania was a more affluent country but the United States, but it just might be. It's possible, okay? So this can be done. And this is where, at least Fresenius is now, is having to price this as to what they think the market will handle. But I think this is the cost thinking that makes the most sense. Some economic tidbits, and some of this should knock your pants off, okay? Our dialysis patients, again, this might be a few years old. I forget the exact where I derived this, but 9 days a year average hospital, all right? That's an average of about 1.4 admissions per patient. So if you've got patients that had no admissions, then think about the patients that did, because the average is 1.4. It costs about 110 grand a year. About half of that is the actual dialysis. All right, and 30,000 of it is the hospital care. The remainder is access care, other outpatient medical care, and you derive that from CMS data. Roughly 6% of the Medicare budget is spent on ESRD, and that's roughly 1% of all the beneficiaries. So you guys know that. It's expensive. All right. So I polled the chief medical officers from these dialysis organizations. And you can see who, if you wanted the names, I give you the names. I mean, you can see who they are, you can guess. So in general, they're all supportive, and they likely will eventually implement HDF in some manner. It's the degree of implementation, so the penetrance of it into their clinics, varies broadly. The suitability and patient selection are likely factors. I'll come back to that in just a minute. The clinics and the staff are busy. The last thing they need is new things happening to them. And they're studying the data and the sciences. And the 2 things that people are studying would be the final 2 trials I'm going to mention and wind down. So the UK trial it's called 4H, and the H's are high volume hemodiafiltration, high flux hemo. There's the 4 H's. And it's a randomized trial. These are the sites in the United Kingdom. The value of this trial is that they will have very granular data. I don't know if any of you have any experience with the NHS, but they know everything about those patients. And that's the data they'll have, and they'll have the cost data. And the other thing is, these are centers that already have experience doing hemodiafiltration. So this would be a very valuable study. The other study is that one using those high cutoff or medium cutoff membranes, and that study is called the MOTHER trial. and that's basically using that Theranova membrane. I won't go through this cartoon, but that trial will be available. I think it says some here when it will be ready. But that's going to compare the actual issues of the Theranova and the high-volume online hemodiafiltration. And this study is being done by some bright people, also very experienced in hemodiafiltration. And so the leader of this trial has a lot of experience with the medium cutoff membranes as well as hemodiafiltration. So that's why a lot of the dialysis organizations are going to pay attention to this trial. So let me conclude. In Europe and Japan, this therapy is applied. It's easy. They've been doing it for dozens of years. They don't have safety concerns, especially with the equipment that they're using now. When you get those convective volume doses way up there, their survival and the quality of life appears to be substantially better. And so I'm just guessing at the cost. I have no insider information. I suspect it might cost 5% more. That's up to the vendors to deal with that issue. I can tell you if you poll the clinics, they're not going to accept a cost like that yet. There'll be other arguments that may change that. But remember that savings in one area can be applied to costs in the other area. So in these global capitated plans, if you're saving hospitalization data, that may more than pay for this. So that's sort of the thinking. So I leave you with this. So here are the questions. Can you name the first 10 presidents? And Chu answered it, no. And then he said, that's one correct answer. All right? So you can reach me there. I will send you a copy of the slides if you want them. We've got time. You've got a few
We have a few minutes. A couple of questions. Please go to the microphone, or you can write your questions on the app, the Q&A portion of the app. Yes?
So thank you very much for the wonderful presentation. I think that in this room I am the only one prescribing hemodiafiltration since 25 years because I'm coming from Europe.
You're an old man.
Yeah. But I studied on your book, so I really appreciated your presentation, really, because this is the basis to understand hemodiafiltration. But I would like also to mention that the complexity of hemodiafiltration does not exist in front of the dialysis machine, because it's enough to click a button and the machine will deliver the right convective volume according to the patient characteristics. I have a comment related to the workload, because I saw that some chief medical officers in the US are afraid about the workload. It does not exist, the workload, because it's easier to prescribe hemodiafiltration compared to hemodialysis. So imagine, for example, saline bags will disappear. No more saline bags. And this is a workload. Imagine, for example, reduction of hypotensive episodes. Reducing of workload. So, I finished.
All right, so no, stay there. So you don't get away with that. All right, anyway, so he does have a lot of experience, and that's the point. And one of the points he's making is that it's really perfected. And when he says that the workload is not, and he gave some examples, that when those chief medical officers said that, that's naivete. That makes your point, is that we don't know enough about it. So if their only experience was with that Nephros device, and they have no experience using modern HDF machines, what do they think? They don't know. That's why we're having sessions like this. So when they answer to me, because I'm talking to them on the telephone, what are your concerns? Oh, well, we're concerned our staff are so busy, they don't need anything new. You just highlighted it's not new, and in fact, it may be new to them, but it's less tedious. It's less accidents, less hypotension. So that's going to be the job of the proponents of HDF, perhaps you, perhaps me, to get them there.
May I make the last comment, because I want to touch the aspect of costs. So I'm a nephrologist since 35 years, okay? So you know that I work for Fresenius, but I'm an nephrologist since 35 years. But when you, as physician, have the power to increase the survival of the patients, to improve the quality of life, to improve the quality of life of the patient for the family members, cost is the driver for your decisions. I would like to understand if you are ethical committed or we are driven by costs.
Well, that's partly why the proms were done. It's a major part of the trial. And just the patient-reported outcomes from the CONVINCE trial lagged behind the mortality by a year and a half. Okay, I sort of know the inside of that, and that's a shame. But your point is well taken. If the patients did better with so many of those parameters, if they did better, their life was better, where do you put a price tag on that? It's another way of saying what you said.
And then last comment. I want to
You said that before.
I want to irritate all of you. I want to irritate all of you, all US colleagues here. So you mentioned Romania, okay? But in our clinics in Russia, 95% of patients are treated by hemodialfiltration, okay?
All right.
Okay.
This is it, to irritate.
All right.
So I have one question from the app. Why not just do hemofiltration rather than HDF? And before you answer that question, I just want to say to the audience, thank you for staying. We are actually out of time, but so if any of you needs to be somewhere, you are excused, but feel free to do your evaluations by May 29th. So, do you remember the question?
Yeah, the question was, why wouldn't you just do hemofiltration? There are some programs that do just pure hemofiltration. I don't know the data from those programs, but I would imagine they're probably coming out of Japan. Is anybody doing just pure hemofiltration in Europe? You guys know? Just pure hemofiltration, not diafiltration. Anybody from the European side?
Hemofiltration, zero.
Zero? Okay. I can't, you know, in Japan, are they doing any pure hemofiltration in Japan?
I don't know, but I would like to say, are we referring to continuous therapy or intermittent therapy?
No, intermittent therapy. Zero. Can't answer that. It's right?
Yeah, yours.
Hi, my name is Julie. I'm a clinical educator from Providence, Rhode Island, in Fresenius. I am not the nurse in charge of education for rollout for the 5000AX, which does provide hemodiafiltration, but my boss is. So I would just like to share very briefly that initial report and feedback from staff as far as learning the new equipment and administering treatments has been very favorable. I did have a very brief intro to the machine, and for context, I've been a dialysis nurse for about 12 years. I've set up a lot of dialysis machines on every hour of the clock, but I learned once how to set up this machine and felt confident that I could perform an assignment. So very, very simple. Very profitable. Did not do that. Very, very simple rollout for teams, and I'm very pleased that myself and my colleagues here are going to be supporting the rollout over this summer into more of our clinics.
Thank you for the comment. And one more, couple more questions. Why has this taken so long to come to the U.S.?
Can't answer that.
Another one, would you include the HDF volume in 13 milliliter per kilogram per hour UF limit?
No. That 13 that person's referring to for hemodynamic stability is net. Is net. So.
Okay, one last one. Is there any change in heparin use compared to HD?
No, it shouldn't be. Heparin will be needed, but it shouldn't be any different than in HD.
Okay, that's it. Well, thank you so much, Dr. Golfer. Very nice. And thank you all for staying.